testing should take place following a myelofibrosis diagnosis?
So diagnosis of myelofibrosis always comes after a bone marrow exam and a physical examination. Often patients have an enlarged spleen and blood count testing and a variety of other laboratory tests. So after that and a diagnosis is made of myelofibrosis, and sort of coincident with the diagnosis, we also often look for molecular markers of myelofibrosis. So these are malignancies of the bone marrow, cancers, if you will, on the bone marrow, although the term is scarier than it was different than what we think of for many malignancies in how it acts. But the myelofibrosis, this is a disease that's characterized by really mutations in the malignant cells, the abnormal cells, in really just one of three genes. And so JAK2 being one of the genes, calreticulin or CalR being another one, and MIPL. And more than 90% of people have a mutation in just one of those three genes. And so often at the time of diagnosis, those tests for those mutations are done, and they help sort of eliminate the possibilities of other causes of myelofibrosis, infections, rheumatological diseases. Sometimes you can have myelofibrosis, but they don't go along with mutations and the sort of same clinical situation. And so at the time of diagnosis, we usually know something about a mutation in JAK2, CalR, or MIPL. More commonly now, and it's increasingly common over the past 10 years, and I would say, in New York City and many places across the country, we also look more broadly for other common mutations in the MPN cells. And these are what we sort of refer in the batch as, next generation sequencing, or NGS panels. And we use the term panels because we're looking at, from a few tens to even, 100 or a couple hundred genes for mutations that occur far less frequently than in JAK2 or MIPL or CalR, but they occur often enough that some of them we use to help guide treatment decision-making or approach to therapy. The reality of it is that the technology to sequence and identify mutations has really outstripped our knowledge of what to do with all of that information. And for the vast majority of people, it comes down to, do you have a marker, a genetic marker that tends to go along with higher risk, meaning a higher likelihood of something that we don't want to have happen. And in that instance, we sort of, although we may be looking at 100 or so genes, it comes down to a binary thing. Either you have or you don't have.
Is there any other testing that you usually want to do?
Laboratory testing for sure. And as I mentioned before, a bone marrow exam. But, physical examination, some people might do imaging of the spleen size. Honestly, I don't routinely do that outside of the setting of a clinical trial. I don't really think it dictates therapy very often. And if the spleen is so small that you can't feel it on physical exam, probably isn't clinically meaningful anyway in terms of, something to treat. It might be there, but it doesn't really change things too much.
How often should patients have a bone marrow biopsy?
So I'll answer, there is no standard in terms of monitoring for myelofibrosis with a marrow or otherwise. My personal approach is I do a marrow when I think it's going to help medical decision making. And so for a patient who's got early myelofibrosis, has been very stable, responding well to therapy, that could be 3-5 years between marrow exams. For somebody who's being considered for a clinical trial, oftentimes a marrow exam is required before they start on a clinical trial and at various intervals afterwards. If there's somebody who had been stable and something is changing, like the blood counts are changing or symptoms are changing, or any of a number of clinical features, then I might look in the marrow to see what's happening there, to see if it explains and can help guide a treatment approach to help people feel better. So there is no single standard, but my personal approach is to do a bone marrow exam when I think it's going to help make a decision.